Thank you so much for inviting me. I work at the University of Michigan now. I have been board certified in family medicine since my residency training in 2007. And my diplomacy in the Board of Obesity Medicine was my pandemic project. I live in Michigan now, but I used to be faculty at the University of Chicago North Shore Family Medicine program, which is really where I developed a passion for teaching obesity medicine, and have graduated many wonderful residents who now practice obesity medicine today. And so I feel like there's still a little bit of Chicago in my heart. So I'm really excited again to join you, and learning objectives are listed in your materials, but I want to spend some time talking about the concept of weight inclusive care and think about some of the things that we do as clinicians and some of the things that society does to affect care for people who are living in larger bodies. And then I'll spend the second half of our hour talking about communication techniques that we can use to reduce weight stigma and applying some motivational interviewing tips and tricks that I think might help us have more positive conversations. Here are my disclosures. But really, the main disclosure I want to make is that I believe that it's possible to practice obesity medicine and to provide weight inclusive care. And I'm really interested. Please feel free to drop questions or comments or thoughts in the chat over this hour, and we'll save time for questions at the end for how you all include this balance, right? This equipoise in your care. I want to acknowledge my colleagues, Dr. Lisa Erlinger and Erin Harrop, who collaborated with me and one of our wonderful medical students, who's now a family medicine resident, on an intervention for weight bias at the University of Michigan a few years ago. And then you'll hear me use the term people in larger bodies, and I'll talk a little bit more as we go about the language that we use and how to foster respectful care. So I'm going to ask you to start thought exercise. No one needs to come off mute, and ask, which individual do you think is healthier? So this is a question that Dr. Erlinger posed at the beginning of our student weight stigma intervention. And what if I told you that the person on my left is at a retreat and she has cancer and she's lost a significant amount of weight, 100 pounds, because of cachexia due to her difficult cancer journey? And what if I told you that the person on the right just finished running the Chicago Marathon and was refueling after their long run? So why do I show you these pictures? It is really just to point out that our brains bring with us baked in some bias and some feelings around body size that are outside of our explicit control, that may link body shape and size with different attributes: health, discipline, virtue, laziness, poor health, and that these assumptions may be inaccurate and they may harm or worsen care for our patients living in larger bodies. And hopefully by the end of the hour, we'll get to a place that we feel comfortable naming and discussing how to address this. We're going to start with some definitions, and I'll start on the bottom with weight normative care, which really implies in some ways that patients are personally responsible for healthy lifestyle choices and maintaining a healthy weight. And this weight normative approach focuses on weight loss and weight management. The outcome is achieving a healthy weight, and then that will treat different health problems. Contrasting that with weight inclusive care as an alternative to this weight normative paradigm gives the assumption that everyone is capable of achieving health in their body, independent of weight, when they are given access to non-stigmatizing healthcare. So the idea of weight inclusive care has been around a long time, and so this is your very brief history shortcut. Lou Lauterbach was a journalist who wrote an article in 1967 called "More People Should Be Fat," about his and his wife's difficult experience living in larger bodies, how they were treated in public and by health professionals. And this article really set up the idea of rejecting the constant diet culture that they were experiencing in everyday life in the 60s. And I feel like things haven't really changed very much in the 2020s. So a few years later, the National Association to Aid Fat Americans was founded, and now that association is NAFA, the National Association to Advance Fat Acceptance. And so, in this milieu of the 60s and second wave feminism, civil rights and disability rights, fat activism really existed as a social movement. And then by the 1990s, we start to see researchers embrace anti-diet culture and body acceptance and start some more critical sociological examination of how diet culture negatively impacts fat people. So we're going to fast forward to 2003, and the Association for Size, Diversity, and Health is founded, and this organization provides education about weight bias and information about health at every size. Lindo Bacon wrote the book Health at Every Size, and this was published in 2008. So I'll take a detour to say that, like many social movements, there's been criticism of health at every size as being white dominated, and there's lots more that I could do a whole different hour in terms of body diversity, race, and racism. But two authors that I would particularly recommend are Sabrina Strings. Her excellent book is Fearing the Black Body, that's in the back, and Sonia Renee Taylor's The Body is Not an Apology. So bringing it to the present, in 2024, Dr. Lisa Erlanger and several of her colleagues founded AWSIM, which is the Association for Weight Inclusivity in Medicine, and there is a medical student chapter version of this as well. Founded in 2024. That is not Lisa Erlanger, that is like a photo screenshot from their website. And so I think we're still even in a growing space of how this movement looks in medicine and specifically in medical education. Going back to definitions, we finished our history tour. I will define weight bias as synonymous with anti-fat bias, and that is a negative attitude or negative beliefs about people in larger bodies. And this includes provider stereotypes, which might be blaming people for their health and weight and health conditions, but even more so this idea of society. And as you heard in Lou Lauterbach's article, this idea of routinely policing the behavior and judging the behavior of people who are living in different size bodies and almost conceptualizing people living with obesity or living in larger bodies as a marginalized population. So in this slide, I will use the word obesity because that's what was used in these clinical studies. And you can see the citations along the bottom of the slides. There's quite a bit of literature about weight bias in medicine. So a study of nurses was found to view patients with obesity as being non-compliant, lacking self-discipline or self-control. Studies of physicians showed that physicians have less respect for people with obesity. In one question, feeling that their care is a waste of time. In one question, ordering less testing and treatment. And then some of the other even more negative stereotypes of intelligence and ability for success. And this truly just mirrors the bias that people are coming into health professions training, how they were raised, and the society that they grew up in. So we can break this down, this idea of weight bias, into explicit and implicit bias. And I'm sure you've all seen this metaphor of the iceberg, that our explicit bias is living under our conscious control, but implicit bias is living under the surface. Although I will say that in our medical student intervention, we used cases and case-based discussion, and certainly cases of explicit bias, hearing from an attending negative things about someone's body size or shape, were experiences that our students raised with us throughout that training. And so to take that one step deeper, some of you may already be familiar with the Stroop effect, but I'll explain it for those who aren't. So by yourself, just read the first line out loud. Blue, orange, green, red, purple. That goes pretty fast, although I practiced this before. And then I want you to try to read the second, third, and fourth lines. Red, purple, blue, orange, green. There is a delay in recognition time. When you're presented with incongruent stimuli, like the word red written in blue, and then researchers can use that delay to infer the strength of different unconscious associations and biases. So going back to the Harvard implicit bias test, the Stroop effect is used where people are asked to sort words that are positive or negative with different pictures of people in different body shapes and sizes, like happy or sad or excellent or lazy, etc. And then looking at that as a whole or aggregate to make assumptions or understanding people's implicit bias. Many of you may have taken this test. There are tests for race and age, etc. But one thing to know is that this isn't really meant to give you insight into your own bias or changes in over time. It's really meant to look at an aggregate at the biases of people who've taken the test overall. And so this was pulled in 2015, over 1 million people taking this test, looking to touch on the idea of internalized weight bias. And I think it's really important to recognize that not only our patients, but ourselves are bringing their weight bias to their interactions with us. Dr. Wells, my internet is saying it's unstable, so someone just interrupt me if I'm freezing. A couple of studies looked at people with overweight and found that a higher level of internalized weight bias was associated with mood problems, body image concerns, binge eating, and decreased self-esteem. And in our study of medical students, we used the modified weight bias internalization scale. And this allowed the students to tell us their own internalized weight bias. And medical students, by and large, have a smaller, like, overall BMI spread than general population. But our students had internalized weight bias that was slightly higher than a group of public health students that took the same test. So I think it's really interesting just to appreciate that this lives inside ourselves as well as inside our patients. But this quote really from a patient highlights how what we say can create this bias and harm inside our patients. So she says, I went for my annual physical having lost 30 pounds and feeling quite happy about this. But the physician came in and looked at me and said, is that all? Needless to say, I was crushed. I left the appointment feeling like I was a failure. I'd never conquer my weight goals. And if that was the case, why even bother? I immediately bought bad food and proceeded to eat my way over the 30 pounds that I had lost. So we appreciate how what we say can affect how our patients feel and the experience that they have in healthcare. And I wanted to explode this out a little bit to talk about weight stigma, more how it operates, in the idea of systemically or how it's baked into our healthcare system. And this can be mistreatment or discrimination or devaluation of a person due to their body weight, size, or shape. So in creating this slide deck and really just looking through the news, at least in my news feed, this is, most of it is obesity and diabetes related. And so just thinking about some of the terminologies that we use, right? We talk about a battle or a fight or a war on obesity. We use epidemic. It's an epidemic or a crisis. We center on medicalization and we center on the economic burden, how obesity and people with obesity are affecting economically the GDP of the United States. We call weight loss the holy grail, right? These new medications are the holy grail, as if having a smaller body size is so desirable. And then we'll talk more about the word morbid, my pet peeve, as we go along. So I want to try to operationalize a little bit how weight stigma then creates more negative health impacts for our patients. And so this slide is from a study by Rebecca Poole and her colleagues based on a meta-analysis and systematic review of 33 studies by Wu and Berry in 2018. And we see a positive association between weight stigma and diabetes, cortisol levels, C-reactive protein, eating disturbance, depression and anxiety, et cetera. And then another study in 2022 by Brown. This was interesting, looking at almost 4,000 patients and separating out people who reported high levels of stigma with low levels of stigma, all who had an elevated BMI. And in this study, it showed that people with weight stigma had higher odds of hypertension, high blood sugar, pain, infertility, et cetera. And so this explanatory model then helps us understand the mechanisms that we can disrupt to reduce the effect of weight stigma on our patients. And that happens through stress that then lead to differential eating and physical activity behaviors, like you heard in that quote from our patient, physiologic reactivity, increased allostatic load, which I think is a fancy way to say stress and increased cortisol levels, and then differential experiences in the healthcare system, which might mean feeling like you've received poor treatment less trust of healthcare providers, avoidance of follow-up care, and delay in preventive health screenings. So we're going to take a little break to keep your minds active and do some not multiple choice, multiple choice. So you don't have to answer, but to yourself, just think about what you think the answer might be. Above what BMI is kidney transplant generally not recommended? 35, 40, 45, or 50? So the answer is that in many centers, the answer is A, 35, but moving towards 40 because the incision for this surgery is made in the pannus area, which can be technically more challenging, but creates discrimination against people with obesity who require kidney transplantation. Next question. Per the American Society of Reproductive Medicine Committee Opinion on Obesity and Reproduction, which is the standard BMI cutoff for infertility treatment with IVF? Is it 25, 30, 32, 35, or 40? So it depends on the center that you send someone to in your local area, but the committee opinion notes decrease in clinical pregnancy and live birth with BMIs over 30. And internationally, that varies between 35 and 50. But this has led to a lot of activism and advocacy in this area, addressing weight bias in reproductive medicine. And your last question, the efficacy of which form of emergency contraception is not affected by weight? Is it A, levonorgestrel, 1.5 milligram tablet, B, ulipristal, brand name is Ella, C, the copper T IUD, or D, all of the above? And the answer is C. Copper IUD is not affected by body weight. And so levonorgestrel may be less effective in people with a higher body weight or body mass index. Different guidelines might recommend for doubling the dose of these medications. And ulipristal should be our first choice for a BMI over 25. But this requires a prescription, whereas levonorgestrel is available over the counter. So I hope you appreciate, and there are myriad examples of these. We could talk about inclusion of people with obesity in clinical trials, where our patients living in larger bodies truly have discrimination baked in against them in the healthcare system. So this comes in, for me, precepting all of the time. Anyone who trained with me can say, like, if you're seeing a patient with Dr. Oshman, she'll quiz you about levonorgestrel and body weight. But the copper IUD might be your best choice for a patient who's had a bariatric procedure. So I hope I've made the case that weight-inclusive care matters and that biases are both implicit and explicit in healthcare professionals, implicit in our patients, and baked in structurally to our healthcare system and the way that we train our trainees. So in the second half of our time, I'm going to talk a little bit more about communication strategies that may reduce weight stigma and some tips and tricks from motivational interviewing that might help us have those positive conversations with our patients. So I'm going to cover 4 different constructs in communication techniques, and those include using weight-inclusive language, using motivational interviewing techniques, acknowledging the complexity of obesity, and focusing on health rather than weight. So you may ask, which words am I supposed to use? How can I get this right? And the first thing that I would say is that our patients, my patients, give me grace every day and acceptance as we figure out what language works best for us. I also think it takes a lot of energy, and most of us are operating with not a lot of energy to give in our clinical day to try something new. In my work, I do gravitate towards these more neutral terms, people in larger bodies or people at a higher weight. In fat activism, it is okay to say fat people. It is not it is descriptive and not insulting. But I think as a clinician, I'm fairly cautious about using that term. I'm cautious about even mirroring that language with one of my patients. Some of my patients I know extremely well, and that might be appropriate, but might be something I wouldn't choose to use without that context. And then person first language is what we've been taught to use. People with obesity and people with overweight, putting the person first. And if you've ever written a journal article, the journal will send the article back to you. If you've accidentally said like diabetic person, they'll, ask you to use person first language, person with diabetes. And so one thing you might want to do, I would invite you to try, is to ask your patients over the next few weeks which words they would like you to use. What terms would you like me to use or say, or what do you prefer to say when you talk about your weight? I tried this over the last 2 weeks. One patient said, "What are you talking about?" The other one said, whatever you want. A third person said, "It's fine to use the term obesity." And a final person, it opened up a really long conversation about the way their childhood was and how their weight was treated. And so I think we just need to appreciate there's a variety of experiences that patients have, and we can use language to help affirm that. And so it made me realize that I needed an explanation for why I was saying this for the patient who said, "What are you talking about?" So one thing you might say is that I want to make sure we talk about your body in a way that feels respectful for you. Many people have experienced hurtful language around weight, and so, your experiences matter to me. I want to know what you prefer. And I'm sure that some of you are wondering what's wrong with person first language. And I was trying to think of a way to talk about this today. And Reagan Chastain is a fat activist and says this a lot better than I can. So I'm just going to read this out loud to you. In truth, this language actually increases stigma because person first language is not being suggested for other adjectives that describe our bodies. No one is advocating that we say the woman was affected by thinness or the man with brunetteness was on the bus. The use of person first language suggests that accurately describing a higher weight person's body is so awful that we have to find a way to talk around it. It shifts the blame from weight stigma to larger bodies. When someone says the woman affected by obesity, it suggests that the problem is her body size, not the weight stigma and the lack of accommodation that's actually harming her. This also goes for the concept that you're not fat, you just have fat. Like, you're not fingernails, you just have fingernails. Again, notice how this isn't applied to other body descriptors. No one says you're not tall, you just have height, or don't call yourself brunette, you just have brown hair. The suggestion that we need to talk around body size in higher weight people in a way that we don't in thinner people is in and of itself stigmatizing. So for me, at least, this really reframed the idea of how when we use person first language in disability health, there is a real goal to reduce disability, and how in obesity care, it may reinforce this idea of differential treatment by body size. So the final point that I want to make about language is ICD-10 coding. Morbid obesity for me is a never do. It's a never say. And yet someone in our health system went through and applied the code morbid obesity to every one of my patients in order to appropriately document my patients' comorbidities for hierarchical care codes and RAF scoring for our Medicare shared savings model. And so I had to go through and systematically remove E66.01 from every one of my patients' problem lists. So the good news is that in 2025, there are new ICD-10 codes that don't use the word morbid. And I think a funny story that after this last set of emails went out, I emailed back the person in charge of billing and coding and then gave a similar talk to them to talk to them about like the language that we use and how it affects our patients. And even though their job is billing and coding and not seeing patients in the clinic, how some of the language even in that email had weight stigma in it. So in 2025, these are your new ICD-10 codes for adult and childhood obesity, and they allow us to more precisely code for the severity of disease and reduce some of that stigmatizing language. So you would use an E66 code that designated class of BMI, and then you would add to that a Z code. So for my patient with a BMI of 38, I would use E66-812, and then I would add Z68.38. which corresponds to a BMI of 38. So moving on, I'm going to switch gears and talk a little bit about some aspects of motivational interviewing that I think are helpful when we think of applying a weight-inclusive lens to our care. So I'll just give you a history that motivational interviewing was first developed in the 1980s by Dr. Bill Miller and really focused on addictions and alcohol use disorder counseling. And it's a way of being with people, a way of coaching people through to uncover and strengthen their own motivations for change. A quote from Bill Miller and Steve Rolnick, who are the founders of MI, is that it's a particular way of having a conversation so that it's the client rather than the clinician who voices the arguments for change. When we're thinking about working towards a health inclusive, weight inclusive approach or a weight normative approach, just helping people towards a weight loss goal, I just want you to appreciate that you're still that best coach. You're still helping your patient achieve their goals through motivational interviewing. So we talk about 4 processes of an MI conversation, and the first is engaging. Do you want to go on a walk with me? Then focusing, where are we going to go? Evoking, why do we want to go there? Is there a beautiful waterfall at the end? Is there a mountaintop vista? And then planning. What's our path? How are we going to get there? What snacks do we need to bring? But all of this work falls on a foundation of a strong relationship with our patients. And what I think we see in medical education is that we're taught a lot about planning. We're taught a lot about how to get to a health goal, but we don't spend a lot of time thinking about helping patients strengthen their own motivation and certainly like developing that rapport. And so one small application that you may already be doing, but might be helpful for you in thinking about a weight inclusive approach is asking permission. And the way that my first MI mentor from my residency program described this was, imagine you're going to someone's house and instead of knocking on the door politely and waiting to be let in, you barge in, walk into their kitchen and start like unpacking things from their dishwasher. It's just polite, right? It makes people feel respected to ask permission before we jump into a conversation about something like weight, which can be very emotionally charged. This could apply to a weight normative approach. We might say, is it okay if we spend some time talking about how your weight is affecting your health? And it might also apply to a weight inclusive approach. Thanks for being here today. Would it be okay if we talked a little bit about your health? I'm interested in any changes you might want to make regarding your eating activities, sleep, without focusing solely on weight. And really the difference here is just the outcome. Where is this conversation going? How am I opening this conversation and to what end? MI, again, is really a heart set. It is my way of being. And so the acronym CAPE, I think of like putting on my cape as I'm entering the exam room and the kind of superhero that I want to be when I'm counseling my patients. And the acronym stands for compassion, leading with respect and value, which is so important when we think about weight stigma. Acceptance, the idea of expecting people where they are. There's an old adage saying that only when I was accepted am I feeling free to change. So letting people decide for themselves what they want. Partnership and collaborating as equals. Patients are an expert in their own lives and what they've tried before, and you are an expert in medical care. And empowerment, which was called evocation in the prior version of the MI textbook. The idea that evoking means that the helping professional is bringing it out of someone, and empowering means more that, like, I think reflects that guiding that you have what you need and I'm here to support you and empower you to do it. Diving a little bit more, because I think this really aligns with the idea of reducing weight stigma and accepting people where they are, is the idea of autonomy support. And so this idea, thinking about a weight inclusive versus a weight normative approach, emphasize respecting that client's right to choose and make their own decisions about their health and behavior, meaning they get to decide whether they want to talk to you about weight loss or they want to talk to you about changing their life behaviors in the body that they have, being healthy in the body that they have. The next step in a motivational interviewing discussion, after we've decided, do you want to go on a walk with me and where are we going? What is the focus of our conversation? Is it weight loss? Is it health gain? Is evoking someone's reasons for change? And we can remember this as darn cats. And that stands for desire, ability, reasons, and needs, commitment, action, and taking steps. So we often guide evoking or empowering patients through asking questions to bring out their own reasons to change. And I've just given you some examples from a weight normative to a weight-inclusive approach as to how we might ask these questions. And in a weight normative conversation, we might talk about desire, right? Why would someone desire to have weight loss? But in a weight inclusive approach, we might just talk about health goals or health gains. What would be your desire to have any improvement in your health behaviors? Ability, what could you do or what can you do? What changes could you make, if any, to lose weight if you chose to? Versus what ability do you have, where you could say what skills or strengths do you have that you'd like to apply to improving your health behaviors? We could look at reasons. What's the biggest reason you'd want to lose weight? And for one of my patients recently, she was scheduled for a hysterectomy for heavy bleeding and had to be in Trendelenburg position. And the surgeon felt it was really important to change her weight prior to that surgery. That was a really important reason. And for someone else, it might be, what are the reasons you'd like to improve your health right now? Needs. Again, strong needs. Again, that could be the same surgical story. What makes this feel urgent right now versus what makes it urgent for you to make a change just in your health overall? And desires, ability, reasons, and needs are really important. Everyone has reasons they want to change. All of you have tried to make health behavior changes in the past. And what we can say is that there is an increased strength or likelihood that someone will follow through with a behavior change plan when they make commitment talk. So we haven't introduced the idea of change talk and commitment talk, but change talk is really just any of the answers to these questions, right? A reason you might want to change. Whereas commitment talk is, I'm already doing it, I can commit to it, I'm taking steps, this is the action that I can take. So I would encourage you to think about the questions that you're asking and how you're evoking reasons for change and whether you want to work with your patients on a weight loss goal or a weight inclusive goal and how to use this language to guide that conversation. I'm going to give you one redirecting question and we'll get around to how to deal with patient implicit bias in a few more slides, but this is credit to Lisa Erlinger that, talking about one of the students asked, what do I do if my patient really wants to lose weight? And this is how she reframed it, asking them, if weight loss was not the most important goal for you right now, how would that change things? What would you want to change about what you're doing? And we can relate this to like losing weight is like controlling your blood pressure or your blood sugar. We don't talk about like blood sugar loss or blood pressure loss in the same way that we talk about weight loss. We talk about the behaviors that get us there, and we can de-link that from a specific weight loss goal. And so you might use that conversation then to come up with an action plan. And that really, for me, means giving people an option of health behavior changes that will get them to the outcome that they want and their goals. We can use a bubble chart for this or a menu of options, and it might include some that you've already put on the chart, but it might include some blank spaces. We know from psychological theory that the idea that the patient comes up with is more powerful than one that we've given to them. So even better if they can come up with their own suggestion. And then apologize to the team because I added extra slides this morning. But this website is CCMI, and I've given you a link to lots and lots of tools that you can use to guide MI conversations. But this is just really a SMART goal worksheet for taking care of my health or well-being. And this might allow you to go through your action plan and your SMART goal. And then it has one MI scaling question. How confident are you that you can achieve your goal? How are you going to stay accountable? And what will you do to reward yourself when you get there? So to wrap up this section, talking about motivational interviewing, and thinking about how it feels for someone to be your coach, your best coach or guide, I'd just like everyone to just think about who that person is for you. It could be your high school tennis coach. I taught motivational interviewing to our fourth year medical students a few weeks ago. It could be your French horn teacher. It could be your debate coach. And how did that person who was a best coach make you feel? That is how we want our patients to feel when we have these positive conversations with them. And, oftentimes I think of like my goal for my patients is to say like, Dr. Oshman is so great. I want to come back and talk to her next week. I had a great time talking about weight stigma and my health goals with her. Many of you may have said to yourself in your head, I feel understood. I wanted to tell them more. I liked them. I felt like they liked me. I felt open and accepted. I felt respected. I felt engaged. I could change. I felt like I could be a better tennis player. This is trauma-informed care. You may have said safe. You may have said empowered, hopeful, comfortable, positive about the future, interested, wanting to come back for more, and cooperative. So my goal in sharing these MI tips and tricks is that not all this isn't a conversation about making certain behavior changes, but I think some of these ways of being with people are really, really helpful. So the last section of this talk, or the next section rather, about communication strategies really thinks about reframing obesity away from a moral failing or eat less and move more, and then you'll be able to achieve a change in your weight. This article, Diagnosing Clinical Obesity, was published in 2025 in The Lancet, and I think there's like over 100 authors to this article. It's a huge international consensus statement, really looking at this idea of staging of obesity, really thinking about applying different levels of interventions to complications and complexity. So I was thinking about how do I talk about BMI as a screening test? And I thought maybe it's like a D-dimer. If someone has an average BMI, that's helpful. It essentially like rules out some of those obesity-related complications. But if it's positive, it doesn't necessarily tell me a lot. So we can see person number one has an underdiagnosis of obesity. We might call this skinny fat. I think my iPad is at the front door, which is very sad because I'm just going to let it stay there and keep talking to you, but you may hear my chihuahua go to the door. So underdiagnosis of obesity, where they have an excess of body fat, but no other signs or symptoms. The next person may have a higher body mass index, but be very muscular, but they don't have excess body fat, and that person is overdiagnosed with obesity. The third case is a person who might have excess body fat, but has no other health complications. I don't love the terminology obesity with preserved health, but we can imagine that that person doesn't have complications. And then the first person has obesity with health complications or obesity with ongoing illness and might require a higher intensity of care. So we can think about, again, BMI, if you look in social media or in the news, like BMI is trash, BMI is racist. I think a more helpful way to think about it is that we need to use BMI as some sort of screening tool, because over a BMI of 35, it probably does relate to excess fat mass, but it doesn't tell you the whole story. There are a lot of different ways that I could talk about the complexity of obesity and really delinking it from this idea of health behaviors. But I think this map is really helpful because it not only talks about brain chemistry and hormonal adaptation in the gut, but it also talks about society and things that are out of people's control, which could be their food environment and food consumption, lack of physical activity in our built environment and cell phones, stress and how that affects our weight, and societal environment. And so I think you all have seen these kinds of formulas for complexity of obesity before, but another helpful way to talk to our patients about complexity of obesity. So all of this has led two major academic societies to release consensus statements about weight stigma. On the left, you'll see the American Association for Clinical Endocrinology, and Carl Nadolsky is a obesity medicine endocrinology physician who lives close to me in Holland, Michigan. And on the right is a statement from nutritionists. So a couple of things that you should pull out from here is the word ABCD, or adiposity-based chronic disease. So obesity really as a disease state is these complications and not just BMI, and we can use a variety of different staging approaches. But I think the most important thing is the last statement here, that weight stigma and bias is a driver of obesity and also a complication of obesity and needs to be built into treatment. And on the flip side, our nutritionists are talking about rejecting diet culture as well as focusing on complications, really talking about health gain, not weight loss, and embracing body diversity. So I want to talk a little bit more about what that would look like. And I think this is just such an interesting study to convey what is health behaviors and what is weight. So we think about different health behaviors: eating fruits and vegetables, exercising regularly, alcohol in moderation, and smoking. And you'll see on the x-axis the number of habits the person is adhering to. And on the y-axis, you'll see hazard ratio for mortality, and you'll see 3 different lines: BMI 18 to 24, 25 to 29, and 30 plus. And this looked at a different population of people from NHANES, the National Health and Nutrition Examination Survey, and did a multivariable analysis adjusting for different variables. And what they found is that of people who had 0 health habits, the hazard ratio for mortality was much higher for people with obesity. But if you looked at people who were adhering to all of those healthy habits, the hazard ratio was the same. And so really this question of blaming or stigma, blaming that person with obesity for it is your weight that is causing the increase of mortality, or is it confounding from healthy behaviors? So this for me is really helpful in thinking about engaging patients in a conversation that does not focus on weight loss. So the final slide on this kind of complexity of obesity really just looks at this U-shaped curve of mortality, and you can see all subjects are in the blue and healthy never smokers are in the red. And you can see that people between a body mass index of 20 and 35 have, for me, like essentially the same hazard ratio of mortality. And even more specifically, if you look closely at the BMI of 25 to 27, having the lowest risk, and 27 to 29.9 having equivalent risk, helps me understand that for many of my patients, some of the fear mongering we do around obesity as a risk for disease can be really counterproductive, and that their risk for mortality is the same. And it also helps us understand that excessive dieting and being underweight for a variety of different reasons, and you can imagine all of those variables that were accounted for, including like smoking, heart disease, cancer, so that this kind of takes away some of that there are other things about being underweight that might be unhealthy. So again, I just want to round us out here with what my patients say. These are my patients. This is Patty Neeson, an interview from the New York Times, but she said, "I think the worst was my family doctor. He made it a habit of shrugging my health concerns off. The last time he said, 'You need to learn to push yourself away from the table.' And it later turned out I was not only going through menopause, but I had hypothyroidism." And another patient who came into the office having lost 70 pounds and feeling really great about herself. The orthopedist came to the door of the exam room and I started to tell him my symptoms, and he said, "Let me cut to the chase. You need to lose weight." He never examined her and diagnosed her with obesity-related pain. So really, again, just going back how weight stigma affects the kinds of conversations and the complexity of interventions that we do with our patient, and how we can use different techniques to put us in a mindset of taking those concerns seriously and making sure that we don't make assumptions. So I want to talk about barriers to practicing weight-inclusive care. And when I thought about what I was going to say to you today, it really, for me, came back to drug companies. Because I think you can all appreciate that we have always operated in a society where there is a quick fix, right? So before GLP drugs, my patients would go to the medical weight loss clinic down the street and they would get a prescription for phentermine and they would lose 20 pounds and they would gain it back. So in some ways, I see this as really just a reiteration of how people are making profit off of creating a market for thinner bodies just using a new tool. And so the way that we talk about this, I think, is really interesting. And this is a study that I just pulled this morning from the Brazilian Association for Study of Obesity. But, when I see these drugs listed as weight loss drugs, one of my residents saw my patient the other day and said, patient states they just want to lose a little bit of weight. This is really tough. I am not saying that this is easy, but I would really encourage all of us to try to think about the words that we use and how we talk about obesity as a chronic disease versus like just losing a little weight. And I try to be explicit with my patients that, like, I'm not really here for cosmetic weight loss. I'm here to make you healthier. And I try to set some really good standards and guardrails around what I'm willing to do and what I'm not willing to do. But I will admit, I think it's really tricky. And I'm interested to hear how that's showing up for all of you in your practices. And some of you may know Mara Gordon. She's a family doctor and faculty at Cooper University in Camden, New Jersey. And this was her post on Twitter a few days ago with a story from NPR. I'm not anti-Ozempic. I prescribe it since supporting bodily autonomy is my duty, but there's a lot these meds don't do. And this links to her article, an interview for NPR. I won't read the whole thing, but just to tell you that, patients who have had a small amount of weight gain and are unhappy with their body, to her, she said to this patient, I'm not sure Ozempic will bring you peace with your body. Medically, I don't think you need to lose weight. And what these medications don't do, they don't undo diet culture, they don't undo distorted body image, and they don't undo weight stigma. And this is her one reframing question that I wanted to give to you, right? To put in your pocket to consider using, which is, what would it feel like to love your body the way it is? And this is something I would probably only pull out with a patient I know pretty well, but like, what a powerful question to ask our patients. We see this showing up. This was in the New York Times 2 days ago, I think, how Ozempic is shaping weddings. And, when we think about a positive way that sustainable weight loss can help health, I was telling a patient yesterday, talking about weight loss, like, when I take my glasses off, I'm still blind. I'm treating my blindness by wearing my glasses. When you stop using your weight loss treatment, medication, whatever that is, we know from clinical studies that your weight comes back. So the thing that worries me most about the way that these drugs are being weaponized in popular culture is to reinforce this idea of weight cycling, which is disruptive to your metabolism, may increase long-term weight gain, and certainly is associated with this idea of body dysmorphia and maybe even downstream cardiometabolic risks. So I put in enough slides that I could skip some if I was running late. So I'm going to skip a little bit of the physiology about weight cycling, and we'll leave these in a new slide deck that you can look at later. But we certainly know that there's metabolic adaptation with weight loss, which leads to some of those weight loss and is highly hormonally controlled. And there's this idea of collateral fattening. The idea that when you lose fat and muscle mass and then regain weight, you're regaining more fat than muscle that can create to negative outcomes over time. So when we think historically about yo-yo dieting and weight cycling and what Lou Louderback was talking about, our job as physicians is to stop that from happening to our patients. So I want to wrap up by talking about these barriers to practicing weight-inclusive care. One might be drug companies. The second might be our weight-centric healthcare training. And so for many of us, at least for me, this was not something that I was ever taught in medical school. And I think by virtue of AWSIM being an organization that was founded 1 year ago, this is really an evolving place to be. But I will just point you to Dr. Lisa Erlinger's website for different CE courses or membership in these organizations. Our healthcare systems put codes in our patient's chart for morbid obesity, right? We fully recognize that value-based care has, again, weaponized or made this like a medical problem to list obesity in our insurance systems and quality metrics. And so I'll just leave you, but not read out loud, these AWSIM principles, which is access to care at every size, making sure that everyone has access to healthy nourishment, avoiding pathologizing body size and shape, right? Welcoming that diversity of body size and patient autonomy, avoiding weight stigma and weight bias, and this idea of considering people with obesity as a marginalized population, and then body liberation, the pursuit of having happiness and joy in the body that you have. So what I take from that is my approach, which is that there's no normal or perfect BMI. You can be healthy and happy and live in a bigger body, and everybody deserves respectful, fat-inclusive care. Some patients may benefit from fat loss, but really, really focusing on that being in a sustainable way. So I've given this lecture for 3 years now to my colleagues at the Beaumont Family Medicine Residency Programs, and I've always ended it with this slide of Lizzo. And many of you may know that Lizzo has lost weight recently, but Lizzo still has a BMI over 30. And I think, again, it's just this beautiful understanding of how we can embrace people living in larger bodies and embrace both healthy behavior changes. Lizzo is vegan, I think, from what I understand most recently, as well as use of medications when they're sustainable. So I'm going to leave my references and time for questions and stop sharing my slides and say thank you so much.
Thank you so much, Dr. Oshman, for that very insightful presentation. We do have a few questions that I'll pose to you now. And of course, if there are any additional questions, please put them in the chat and we'll look at those. So the first question is, oh, sorry. How is it discriminatory if the effectiveness or clinical treatments are affected by BMI?
And so what I assume this question is asking, or my understanding of what you're asking, is the need to tie different weight treatments with potentially a different BMI cutoff. And it kind of goes back to that idea of BMI being a very imperfect proxy for severity of obesity. And so there are a few different paradigms, but I was waiting for that Lancet article that gave some consensus around severity of obesity, because I would tell you, even amongst experts, there is wide variety in how we're staging obesity. And so, if I had my way, I would apply the most intensive treatments like bariatric surgery and highly effective incretin mimetics to people with a BMI over 40 or those with severe complications. And again, I will just contrast that to what a drug company wants to do, which is to create a market for its drug so that those medications now are useful for anyone with excess fat mass. And I, again, really think for us as clinicians, as you gain more experience and comfort with weight management, is using your whole host of tools, from primary prevention to dietary and lifestyle change to older weight loss medications or weight management medications to surgery, to make the changes needed for many of your patients. I was giving a lecture at the University of Michigan, and the keynote speaker was the chief scientific officer for Eli Lilly. And I asked him, like, I would like an Ozempic light. I would like something for my elderly patients that helps them be a little bit healthier, but not lose 30% of their body weight, because that's not going to be healthy for them.
Wonderful. Our next question is, oh, sorry, my screen is coming up. So, what to do when the EHR doesn't display a patient with this condition, like a condition of obesity?
I have used Epic. I have used Centricity, which I like a little bit less. I've used different EHRs, and each of them have different capabilities. So I would recommend going back to see what you can do. What I do is I change the visible language to my patient. So I just saw a patient last night with a psychiatric condition that she's really, really distressed about having on her chart. So we like worked on it together and used ChatGPT to come up with language we were both agreeable with. And then we changed, like, it would have said like paranoid schizophrenia with blah, 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 to whatever it was, that now when she sees that in her medical chart, the language changes. So we have that ability. I'm not sure if you do. And again, I think this idea of what does your patient prefer? I think from a fat activism perspective, we would say, like, don't put it in the medical chart. It's not a disease. And so I think each of us are dealing with that. Like, that is the structure built in that makes it really difficult when our health systems are asking us to bill and code for these things. So you could do conscientious objection and not put it in the medical chart.
Um, Thank you for that. Christine was clarifying the question earlier, about
Yeah.
the term discriminatory that was used, and states that she was addressing the birth control example, that they may be
Mm.
less effective, but the term discriminatory was used.
So
That's
the thing that I think is discriminatory, because that is such a great point, is the lack of over-the-counter access to emergency contraception, right? The piece I think, like what's baked into the structure that's more difficult is how hard is it to get a copper IUD if that's the appropriate emergency contraception for you versus someone else who can get an over-the-counter option in the drugstore. I totally agree with you. Like the discrimination is how it ends up affecting access versus then the treatment itself.
okay. Thank you for that clarification. Next question is, do you add a Z code when you bill?
I probably should, but I am an imperfect human, as are the rest of us. And so, yes, I try to. It really depends on what I'm billing and coding for. And oftentimes, if I'm just billing a 99213 or 4 code and the person has multiple comorbidities, I will just be honest and say I do not always do that. I try to.
All right. The next question I answered in the chat, and the next question is, thank you, Caitlin, for your reflection there. And the next question is, can you talk about the social stigma surrounding GLP-1 and how this should be discussed if a patient brings this up?
I touched on this a little bit, and I think there's two social stigmas. There's stigma about taking the medication and stigma to be thinner. So I'll address both, and Jean, please share your thoughts about which one you were thinking of specifically. But when I started using these drugs 10 years ago for diabetes and then for obesity, no one wanted to take them. Like it was like pulling teeth to get people to take an injectable medication because of the bias we carry with us on insulin. And so, what is fascinating to me is the shift in people's willingness to take a medication. And I think it again just goes back to how we see our bodies and, this idea or drive for thinness. Jean, I think it is a really difficult thing to approach. I would offer some of those example reframing questions. If weight loss was not your goal, would it be? Um, Different speakers later this afternoon will talk more about like delivering obesity care. And oftentimes I'll ask people, what is your goal weight? Not because I'm endorsing them getting there, but I want to have a read on like 50% weight loss is maybe something that we're going to talk about and understanding the change. And even with our more effective anti-obesity or incretin mimetic medications, my patients are really disappointed when they say like, oh, I'm only going to lose 15% of my body weight. And it leads to a really powerful conversation about like, well, let's put that off to the side. What other health goals were you hoping to appreciate? So I'm not saying that these medications are wrong because they are very effective, but I'm thinking about the way that we apply them to our patients.
Very, very insightful. I just think about, I love that we're doing this conference and we've called it Redefining Obesity Care, because I do think we need to think about um, people, as you said, people at higher weights, how we address that. And are we thinking about, and I'm going to talk more about this in my later session, but, you know, is our focus on thinness or is our focus on health? And it seems to be that it's thin. And what I tell all my patients is I don't care how much weight that you lose, it's not going to make you healthy. And I think that we have to shift the focus to encouraging a state of improved health and not encouraging a state of thinness, because you can be thin and have health problems as well. And I think that we don't do a good job of really emphasizing those points. And of course, culture doesn't help either.
Christina, I think like you could have given this talk. We all could. And I think all of us have different insights. So I'll just end by saying, Sapna, I will put another slide back in the
Oh, okay.
slide deck that lists BMI cutoffs for different races and ethnicities and some of the data supporting that. But you are absolutely correct. And again, more discrimination or bias, that is not reflected in the FDA approved indication and cutoff for the medication. So this is where it gets a little trickier advocating with insurers to cover a drug and when our different ethnicity-based risk factors don't match that kind of white normative number.
Right. Thank you for that.